Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to go through in a way that I've done many times before to try to jump off of an article to have a more general discussion. So the article that I'm looking at here is once again, as is consistent for me, from the International Journal of Osteopathic Medicine. This is currently it's in what is called the issue in progress. The title is Perceived Benefits and Limitations of Game-Based Simulation Education by Osteopathy Students in Early Clinical Training, a Preliminary Mixed Methods Study. So when you hear mixed methods, it means it's going to be both quantitative and qualitative. So they're looking at some form of measurable outcome, and then they're also doing some form of interview. So they're asking qualitative questions. Maybe saying interview isn't as ideal as it could be, but essentially they're asking for opinion as opposed to observing outcomes or measurable performance is probably a better way to say it. So again, I'm using this as a jumping off point, so I'm going to talk about it. I'll go through the article and then I will once again abstract and extrapolate from there. So the abstract to read, game-based simulation education is becoming an integral component in healthcare programs. It is defined as any educational activity implying simulation procedures to recreate clinical scenarios. Previous studies have shown that simulation can improve patient safety by enhancing healthcare providers' competencies. However, few studies have investigated students' perceptions of simulation within osteopathic programs. So when you're looking for problem gap hook, so identify a problem. What they could say is that the problem is that we haven't properly investigated the perception of students. The gap is specifically that it hasn't been done. Maybe I'm doing that. It's a little off key. And then the hook is that, well, now we can do it, right? So there's this gap essentially in these researchers' mind that how did they say it? Few studies have investigated students' perceptions of simulation within osteopathic programs. So when you ask people for their perception, you're going to get a variety of qualitative feedback that you have to figure out a way to interface with. And so to go back to reading, the aim. This study aimed to measure and compare year 3 osteopathy students' perceptions of a game-based simulation versus traditional clinical training. Measure and compare the perceptions. So there's a measurement of the perceptions. It seems sort of weak on the mixed side or on the mixed methods. So the quantitative, I don't know about measuring perceptions. You can ask for perceptions and then you can code them, and then I guess you could do something like that. But it's an interesting construct to measure perceptions. It's not impossible, but in this case, it's somewhat interesting. Methods. To read again. Year 3 students at the end of their 12-week clinical training were invited to participate in this research project. This included filling out a Likert-based survey and semi-structured interviews. There you go. There's the Likert-based survey. So a Likert scale is an anchored scale, usually 1 to 5, sometimes 0 to 5. So there could be 6 options, but generally it's 5 options. It's the strongly disagree, neutral, agree, strongly agree, stuff like that. So that, I guess, they would have used something that would have been previously developed to anchor on and measure there. So I hadn't necessarily pre-read this. I looked at the title and saw some stuff where I could jump off of. So if you use a Likert scale, as long as the Likert scale is appropriate, and sometimes it is and sometimes it isn't, then you have some form of pre-agreed upon quantitative measure in some way, shape, or form. So it takes a quality and flips it over into something that could be measured as anchored to certain concepts and terms. To go back to reading, the semi-structured interview is the more qualitative side. So it's free for the people to report how they want to, whereas the Likert scale is heavily constrained based on the options that are available. To go back to reading, 3 clinical training modalities were implemented and evaluated: a demonstration clinic, a video streamed demonstration clinic, and a game-based simulation called the clinical battle. So to continue reading, results: 67 year 3 osteopathy students completed the surveys and 8 students were interviewed. The clinical battle was significantly felt as the most engaging, most useful to gain feedback, and least stressful of the 3 training modalities proposed, with a confidence interval greater than, less than, whatever, 0.05. So in what they did, it hit statistical significance. The clinical battle was also perceived as similar to a demonstration clinic in formulating a diagnosis and for reflective practice. The semi-structured interviews offered deep structured explanatory narratives drawn from thematic analyses. 5 themes were identified: engagement, clinical reasoning, improvement, stress, ideas for improving clinical training, and reflective practice and self-assessment. To go back to the top of that, the 8 students, so at least in the abstract, they haven't noted whether they hit sufficiency with those 8 students. They may very well have, such that when you're doing interviews, no further themes are observable or evident from a subsequent interview. You've reached a level at which you are finding no new insight from interviews, so you stop your interview process in a qualitative approach. So that could be okay, that may not be okay. It completely depends on what the full text, which I can't currently access, says, but that's a point to just reiterate the concept of sufficiency with qualitative research. The conclusion, to read again: the simulation-based training implemented in the study was positively perceived by students for their clinical education. Future research could focus on the effectiveness of game-based simulation versus traditional training on clinical competencies acquisition. So that part, the opportunity for future training, that's really interesting, because what they're suggesting in their future training is to anchor on, or at least observe, outcomes from one form of training versus another. So you'd have to, and they probably do, have an agreed upon scale to measure competencies, such that when you put people through either the clinical battle, the simulation-based clinical training, or the in-person demonstration, and then you look at the competency measurements subsequent. If they are the same, you can choose the one that people claim to like more. If they are, because now you have 2 constructs. So a construct being something that is identifiably itself and not other things. So the construct of performance outcome and the construct of enjoyment or liking something better, for lack of better terms. So if the in-person demonstration and the simulation have similar performance outcomes, then you can bring the perceived enjoyment up in the hierarchy and say, well, now that these are the same, the clinical or the competency outcome is the same, I can lean towards the one that people claim to like better, because it's another category or construct to consider. What I tend to call perception-based data is a customer service construct. Now, customer service is very important, but even in education. So this allows me to sort of have my jumping off point. Constantly asking what people like is okay if you can prove that regardless of the method that you utilize for training, you get the same performance outcomes. So if performance outcomes are even, then you can go on to the modality that people enjoy more or claim to enjoy more. But if the performance outcomes are uneven, then you have no choice but to go with the one that provides the highest performance outcome. Especially in healthcare, because it's the performance outcome, the interface between the individual seeking treatment and the individual essentially working with that person to provide some technical skill in the form of treatment. That's the most important thing. The most important thing is the performance outcome. So if performance outcomes are not equal, it doesn't matter ever what the student likes. The student needs high-level performance outcomes so that they can appropriately interface with the future person that they're going to utilize their technical skills in conjunction with. So for lack of a better term, the patient requires that this practitioner goes through the training that provides the most appropriate performance outcomes, regardless of whether they like it. Only when different modalities of educational delivery have the same performance outcomes can we consider the construct of preference or enjoyment or engagement. So the fundamental thing that I'm really aiming to target is to say there are times when the perception or the enjoyment matter far less than the performance outcome. With respect to osteopathic treatment, there is seemingly an arc where osteopathic practitioners culturally prefer the patient experience or the report of the patient experience. In another set of terms, they want to know if the patient liked it, versus utilizing as objectively as possible some form of performance measure. Now, in the case of osteopathy, the performance measure would be alteration in movement pre and post testing with the same test. So whether it's yield to pressure of soft tissues, you squish the soft tissues and they either squish or they don't relative to their neighbors, or relative to the same tissue on either side in any given area, or large joint movements or even small joint movements. Either they are found to be restricted and changed, or they are found to be restricted and they don't change, or they are found not to be restricted and there's no need for change. So culturally, osteopathy seems to show some overarching preference in the hands-on realm for whether or not the patient liked it. That does not matter as much until all of the approaches have the same performance outcome. If performance outcomes are equal, then you choose the one that the patient likes. Now, the nice quirk about osteopathy with respect to how care is delivered is if you're using the barrier concept appropriately, you sort of get both things at the same time. But the barrier concept is really responsive to how the patient responds to the movement so that you can get as much movement change as possible. So it's always centered around how the patient responds. There will be patients that do not enjoy the method that does not engage contraction and protective mechanisms, and there will be some patients that really ask for you to go rough and create a bunch of heavy pressure and essentially, for lack of a better angle, protective mechanisms within their body while you're providing the treatment. That is less clinically relevant within the scope of osteopathy because osteopathy has that barrier concept, which means that what you're looking for is to increase movement without engaging protective mechanisms. The way that I tend to say that as a heuristic or as a rule of thumb that will guide your decision making is don't make them say ouch. If you can go in the direction of restriction and they do not actively contract their muscles or give you any other sign of abrupt response to abrupt movement, which could be termed a pain response or at least a protective response, then you can go direct. If they engage some form of abrupt response to abrupt movement, which could be called a pain response or a protective response, now it is your job to make the soft tissue soft. You have to avoid that protective response. That is what the barrier concept does. That's what sets osteopathy apart. So the interesting thing is that I can engage the concept of stated versus preferred preference. Now, the preferred preference or stated or acted, chosen preference, something that you can observe through behavior as opposed to observe through words. I may be saying it a little bit funny, but essentially somebody says they like thing A, but really if you watch their behavior, they like thing B. The barrier concept is always looking to observe how they respond. So which movement do they respond best to? In other words, which movement do they not really, movement or set of movements do they not really respond actively to? So no abrupt changes in the form of contraction, facial expressions, or audible noises to abrupt movement. So no abrupt changes or responses to abrupt movement, which means that you're doing the barrier concept properly. Now, the patient can say they want deep pressure. The patient can say that they're looking for more. The patient can say that they don't like it when you are working appropriately to the barrier concept. So their stated preference is that they prefer a certain type of pressure, but their actual observed preference is that when you do what they ask you to do, they respond contra to appropriate use of the barrier concept. So you can have this dichotomy, so people can like it and it can work bad, right? So the thing that will always drive your treatment approaches is the outcomes and the responses. So the barrier concept makes sure that you don't make them say ouch and that they don't have any abrupt responses to abrupt movements while you're treating. And then if that did what you needed it to do, you will be able to observe altered motion with the same test from the initial test. So you found it restricted, you worked on it and didn't make them say ouch, and now it's changed in the desired direction as far as movement is concerned. So we're always, as osteopathic practitioners, going to be working on the patient's observed preference. And there will be times where there will be struggle because it will be counter to their stated preferences. So this is where these hierarchies play against each other, because if you get a positive outcome osteopathically with hands-on treatment, approaching with proper respect to the barrier concept, the patient may get a positive result and not like it, right? So that's where your customer service concepts come into play, and how you interact with people does matter, because if you are not interacting with them in a way that they will not be deterred by, they will not feel comfortable returning for treatment. So I will consistently say that customer service is not necessarily the top of the hierarchy, but it matters. Or doing things that people say they like is not the top of the hierarchy, but it does matter. It matters more when all approaches have the same outcomes. So if all hands-on approaches, whether you generate protective responses or not, have the same outcome, then you default to the one that will give them that outcome. When it does not, then you have to default to the one that provides the best outcome, because that is your duty as a hands-on practitioner, to get the best performance outcome for the person, or the most clinically relevant outcome, because that is the realm in which you work. It's an obligate physical reality. You work outside the patient. There's lots of stuff you can't observe, but you can observe how they respond on a macro level with respect to either the lack of or presence of abrupt responses to abrupt movements. So once you sort of balance that out, you can make better choices. The way that they went about this study, there's nothing wrong with the study necessarily that I can tell from the abstract. They went to preference before they went to performance. I would almost always suggest that you err on the side of identifying performance outcomes and comparing those prior to asking about preferences. Now, the neat thing about research is that if you set up two different approaches and you can measure them on the same performance metrics at the end, you do that, and at the same time, this is your actual standard mixed methods. You can give them a Likert scale, and you can give them the structured, semi-structured or structured interview, and find the qualitative information at the same time rather. So you can get the performance metrics from the two interventions, and you can ask if they liked it either way, right? So I would almost always, with respect to healthcare and technical skills, especially within osteopathy, because that's what I'm doing, I would err on identifying performance metrics first, and as a subsidiary to that, or lower in the hierarchy, the preferences or the enjoyment or the engagement. If the outcomes are equal, I'll go to the one they like. If the outcomes are not equal, I will always go to the one that provides the better performance outcome, regardless of whether they like it or not, or report that they like it. Because one of the classic problems with things like surveys, things like opinion polls, and things of that nature, are that people will not necessarily report what they really like. They may report what they think will not get them kicked out of their social group. So there's a known error in reporting and collecting that data, or collecting and reporting that data. There's a known common error. So you want to be very cautious with that. But if these authors had have simultaneously collected performance outcome data on the competencies while they also ran their qualitative side, then this would be much more complete, and we would be able to make a more informed choice already. So sometimes when you're doing research, you want to set it up so that you can get multiple angles of data in a relatively short period of time, because within that 12 weeks, they could have delivered the training, and really their measurement is at the end. They test competencies in either group or in all three groups, and then they ask those questions about preference for which style they wanted or they enjoyed the delivery of, right? Or because they're not mixing, they're not crossing over, so really you're asking about varying things and figuring out which group liked it the most. So it's a little fuzzy, but they could have extracted that data simultaneously with very little effort on their part. So I think they did a fine job. I would have preferred to see them look at the performance as the top of the hierarchy and the preference as the second level in the 2-box hierarchy. And to return and reiterate, the patient liking things matters, but it matters less than the clinically relevant outcome. So default to the clinically relevant outcome as often as you can, and be respectful of the fact that there's a human there. So don't do or behave in a way that will turn them away from approaching some form of interaction with you as a healthcare professional, but don't necessarily default to pandering to their requests. Clinically relevant outcome is number 1. Preference is number 2. Unless all clinical interventions have the same outcome, then you absolutely go to the one that they like. So to present that as a possible hierarchy or a suggested hierarchy with respect to how you approach osteopathic practice and osteopathic care and osteopathic education. So thank you for listening this long. Hopefully you found some of that useful, and we'll talk again soon.